Hello, this is Dr. Turkmani, consultant in cornea and cataract surgery, and in this video I'm going to present a very interesting case of cataract surgery. This patient was referred to me from my colleague, and the referral letter mentioned that this patient had a Phaco attempt, and after the incisions were done and Viscoelastic was injected, there was profuse subconjunctival bleeding, which led to the need for stopping surgery, with the referring consultant not being able to even wash the Viscoelastic out from the anterior chamber. So in review a few weeks later, significant atrophy of the iris with a fixed mid-dilated pupil was noted, and obviously the patient was still having a cataract. So there was a question whether this bleeding could have come from the subtenon block. The referring consultant was planning to do the case under general anesthetic, but after discussing with me, we agreed that I could do a topical attempt for this case, and I just took the case for surgery. So I'm starting by doing the main incision, 2 side ports for the aspiration cannula, and then 4 ports with the MVR blade for the iris hooks. You can see that the iris is showing a significant degree of atrophy, and also there's a very dense cataract with no red reflex, hence the need for vision blue. I'm also using Helon GV because it was a rather shallow anterior chamber, and the reason why I'm doing counter force for the incisions with cotton bud, it's to avoid any inadvertent pinching of the conjunctiva that could lead potentially to the same problem described in the initial surgery. So after I've put the hooks, I'm surprised to see that in the temporal sector of the eye, which is inferiorly in the image, I can see the edge of the cataract, I can see the edge of the lens, which means that not only there has been a glaucomatous event from Viscoelastic not being washed out, also there is some degree of damage to the zonules, which is causing the cataract to be tilted nasally, and absence of zonules temporally. And of course this is a very important finding, because through the absent zonules there is a risk that anytime throughout cataract operation there can be vitreous presentation that can obviously change completely the course of the surgery. I'm starting now capsular, and as I'm going through, the zonules seem to be, the rest of the zonules seem to be reasonably stable. I'm being able to complete the capsular with not much of a problem. And I'm able to get a capsular of about 5.5 to 6 millimeters, which is big enough to take the cataract out. This was a very dense cataract, so it's important to have a continuous rhexis, and also for this to be big in size. Now, after I've done hydrodissection, I'm rotating the lens, and in cases with weak zonules, I use Tusinski hooks, so I do bimanual rotation, and then I don't apply the forces just in one direction. The forces are counteracted by the bimanual rotation for more stability of the zonules. Now I'm starting with Phaco emulsification, and in cases of very dense cataracts, my preferred technique is stop and chop. You can see in there the weakness of the zonules, how mobile is the lens bag complex, and this is also a very tricky situation because it's a very dense cataract. So at some point I thought whether I should convert to extracapsular, but we have to bear in mind that this case was being done under topical anesthetic, so it's again not the best situation to try and attempt a conversion to extracapsular with the patient being under topical anesthetic and the expectations of the iris being floppy and the possibility of iris prolapse. during the process, so I just thought it's just a matter of being patient, continue grooving, continue doing the trench, and at some point it will be deep enough for proper cracking. Again, rotation was not very easy, especially given the weak zonules, so I didn't want to exert any extra effort on the weak zonules. I fill in with viscoelastics again and do bimanual rotation of the lens. Cracking was incomplete because of a leathery posterior plate, so in this case again the two Sinskey hooks are very helpful because I can go really deep in the pre-cracked groove and I can continue digging deeper and deeper till I can see that there is a really nice clean break. When this is achieved, again my goal here is to reduce as much as possible the fluidics and the phacodinamics in order to avoid vitreous presentation from the zonules. So what I'm doing here, you can call it a zero vacuum, zero irrigation technique. The Phaco probe is only used to do a counterforce against the chopper, but no vacuum is used, no irrigation is used. The AC is held just by the Viscoelastics fill in, and then I rotate the cataract and do the same maneuver with no vacuum, no irrigation, just the chopper and the counterforce of the Phaco tip. I'm cracking the other half of the cataract till I have 4 quadrants. You can name it if you want, no vacuum, no irrigation technique or cracking. And now I'm ready to proceed with elimination of the fragments, emulsification of the fragments, taking extra care that no vitreous presentation would happen through the zonules. Now when the fragments are removed, in this particular case I just noticed that a small fragment remained enclavated in the angle, and I don't want to go with my Phaco probe for such a small fragment with a floppy bag, so I just push it with Viscoelastics. And I do what David Chang has described as viscoelastic trap. I just inject viscoelastic substance to keep that piece in the anterior chamber, and I am able to manipulate underneath and complete safely aspiration of soft lens matter. Now I'm filling in with Viscoelastics again, and this is a second technique again described by Professor Agarwal, which is called IOL scaffold. I'm putting the IOL in the capsular bag to protect the posterior capsule, and now I can safely go with obviously reduced vacuum parameters to remove that final piece of the cataract which was in the anterior chamber, and finish off this case of subluxated cataract under topical anesthesia with removal of the iris hooks. Thank you very much.